Okay, we're gonna, Lord, we're gonna go ahead and get started here. The OB team is doing the fetal boards. Mainly Dr. Delhomme is going to do the meat of it. And I suggested this topic because it seems recently I've had a couple of patients come over, they're AMA, they might want an amnio, then I look in their chart. No one's done a type-in antibody screen. And then I talk to that young resident, they go, oh, she had it her last pregnancy. And they're like, no, we do it every pregnancy. So, and then we had a couple of patients with some antibodies. This one we're going to present. We have a couple that actually are coming up with some more unusual antibodies that seem to be doing well. So I'm going to turn this over to the OB team.
Good morning all, I'm Andrew Bell. Can you hear me well? Okay. So the presentation today is on alloimmunization in pregnancy by myself, Dr. Huddleston, and Dr. Delhomme. The goals of this will be to review our basic immunology as it pertains to red cell alloimmunization, to discuss the diagnosis and management of thus, and to review the immunology regarding antibodies and antigens, discuss how mothers become immunized blood group antigens, review both the common and the less common antibodies, discuss how Rhogam functions to prevent alloimmunization, learn about screening for alloimmunization, and review monitoring and management guidelines once a diagnosis is made. So our patient today is Miss AM. She's a 35-year-old G3, now P1203 African-American female, diagnosed with hepatitis C, who in her previous pregnancy was noted to have anti-KID of the subtype JKB antibodies. She was followed by Drs. Rhogam and Brouillette regularly with fetal monitoring and middle cerebral artery Dopplers. Between 24 and 28 weeks, her middle cerebral artery Dopplers were all within normal limits. At the first time at her 28-week visit, her MCA Dopplers were found to be increased to a critical level above 1.5 multiples of the median for her gestational age. Her NST that day was also non-reactive. So she was admitted to the labor unit at 28 and 4 for continuous monitoring, a course of steroids, and repeat MCA Dopplers. At that time, Cordocentesis would have been a good option, but we were unable to perform it due to maternal diagnosis of hepatitis C. Once her course of steroids was completed, her testing was reassuring and repeat MCA Dopplers were below 1.5 multiples of the median, so she was discharged from the hospital for close follow-up in the perinatal center. She was again followed by Dr. Rhogam and Brouillette between 29 and 32 weeks, and during those visits she had MCA Dopplers within 1.5 multiples of the median. But at her 32-week visit, she again had a critical level in MCA Doppler reading, and again her NST was also non-reactive. So this is a visual that gives you an idea of what an MCA Doppler will look like in irregularity. As you can see, the peak here is her maximum MCA velocity. It was at 72 centimeters per second. And this is a plot of the gestational ages are on the x-axis, centimeters per second for MCA Doppler recordings are on the y-axis. The white line represents median for gestational age. The flow velocities in centimeters per second for MCA Dopplers increase throughout pregnancy, and all of the plus signs represents measurements that were done during her pregnancy. The one we just discussed at 32 and 4 is yellow. It's the third that was outside of the critical range of 1.5 multiples of the median. Subsequent to that, she was admitted to the labor unit again at 32 and 3. She received a rescue course of steroids, and she was delivered shortly thereafter due to the critical MCA Dopplers, equivocal fetal testing, and an inability to perform cordocentesis due to her diagnosis of hepatitis C.
Okay. So I'm going to talk a little bit about basic immunology. First of all, just some quick definitions. An antigen is going to be any substrate that's a target for and elicits an immune response from T and B cells. An antibody is a protein produced by a B cell that identifies and helps in the removal of foreign threats, aka antigens. So there's kind of two types of immunity. We're going to talk mostly about the second. The first is innate immunity. It has to do with your macrophages, your natural killer cells. And then your next type is your adaptive immunity. That has to do with your T and B cells and kind of your antibody production in response to antigens or threats. So your B lymphocyte is a white blood cell that's responsible for producing the actual antibodies so they'll be what contacts the antigen via the antibody protein on their cell surface, and it will cause the differentiation and proliferation of several of the same type of antibody. So your plasma cells are made in the bone marrow. They're secreted through blood and lymph, and they're a type of B cell that's in charge of secreting large amounts of antibody. Once there's an initial exposure to an antigen, the plasma cells are kind of what mass produce once the patient or the blood is re-exposed to that antigen. So this is just kind of a picture of the makeup of the immunoglobulin. It's a heavy chain and a light chain. Each heavy chain and light chain have a variable region, as you can tell here, that will interact with all different types of antigens. So these are the different types of immunoglobulins, just to go over really quick. Your IgM is your largest. It's going to be a pentamer. It is the first immunoglobulin to reach the site of infection or the site of antigen. It's basically your acute response. So in a patient that has an acute infection, you'll see an IgM rise. Your IgG is going to be a dimer. It's the most abundant in the body. Also, it's found in intestines and lymph. It's the most important in the secondary immune response. So once you have that acute phase with the IgM, the IgG will eventually take over, and that's what can remain positive. With your IgE, that's going to be your hypersensitivity, your allergy responses, and release of histamines. And then your IgA is actually has a special secretory component here that allows the passage of this immunoglobulin through mucosal surfaces. So you'll actually get secretion of the IgA into colostrum in the breast milk, tears, saliva, respiratory, intestinal, and genital tract secretions. So what happens with the Rh immunization is that there's an interaction between the fetal blood antigen recognized by the maternal immune system as foreign. This usually is limited to hemorrhage prior to birth with any bleeding and also at the time of delivery. So the antibodies on the B cells will bind to the fetal antigens and cause basically a maternal immune cascade. There's a short-lived IgM response, like we talked about, followed by the IgG production, and then proliferation by the plasma and memory cells of a whole bunch of antibodies. So this is just a picture of some of the antibodies. You can see some of the common ones that we see are Kell and Duffy. This is just to show that it's in the cell surface membrane. So in terms of your ABO blood types, your O blood type is going to have no antigens on the surface of the red blood cell. Your A will have A antigens, B will have B antigens, and then your AB blood type will have A and B antigens. So with repeated exposure to the same antigen, like with Rh negative patients, the memory cells are going to cause a release of IgG. And basically what you'll get is extravascular hemolysis, so hemolysis of those red cells, which most commonly will occur in the spleen. So Rhogam is an antibody that actually prevents the maternal immune response from mounting that immune cascade to the fetal antigen. So it's a polyclonal IgG that's derived from human plasma. It's purified through ion exchange chromatography. It's also filtered to eliminate any viral transmission, just like you would for blood transfusions. So it's an IgG to the RhD negative. It binds with high affinity. It competitively blocks the RhD from interacting with maternal B cells and inhibits that cascade. So this picture is just a picture of a fetal cell with the D antigen on it. Rhogam is acting to inhibit the maternal cell from seeing this as foreign. So with every new pregnancy, like Dr. Brouillette talked about, you need to get a type and screen on those patients, especially with our patients. You don't know their past history, if they had a blood transfusion in their last pregnancy. So you get an ABO and then the Rh blood type. You also will get an antibody screen with that if it comes back positive. It should also be repeated at the 28 weeks when you do administer the Rhogam. So these are some of the examples of the different types of red cell antibodies. There's a lot more than this, but with the CEL, this is frequently associated with severe disease, and this is most commonly seen in patients that have gotten a blood transfusion. And then anti-C is the one that we really worry about, and it's associated with the severe disease as well. This is just a picture showing you a red blood cell with the antigen and an antibody. So if the antibodies are found in these patients on the type and screen, the next thing to get is going to be a titer. A critical value for most of your antibodies is going to be 1 to 32, but with CEL it's actually lower, it's 1 to 8. You need to repeat the titers regularly to kind of see if there's a progression in the alloimmunization. You repeat that monthly until they're 24 weeks gestation, and then every 2 weeks until they deliver. So you have a patient that's Rh negative with positive antibody screen. So the next step is to test the father. Obviously, you want to make sure that the father, that the patient, who the patient claims is the father, is actually the father. So you want to make sure that paternity is assured. So there's 3 possibilities. You can have a father that's negative. If he's negative and mother's negative, then there's no need to further screen. If the father's a heterozygote, then you need to get fetal cell-free DNA to test for their Rh status, or you can amnio for that. And then if the father's a homozygote, then it's going to matter what the fetus is. So if the fetus is negative, you don't need any further testing. If the fetus is positive, then you need to start testing for the MCA Dopplers and monitor those. And this is just kind of a graph showing the same thing.
Hey guys, can y'all hear me? Yes. Okay. All right, so I'll kind of take it from here and finish out. Like Lise was saying, back on this slide, you look at paternity of the father. If the father is negative, like you said, no testing is warranted. But if the father is heterozygous, then that's when it kind of depends on the fetus. And you can do the cell-free DNA testing or an amnio to test for it. So then if the fetus is negative, there's no further testing warranted. But if that fetus is positive, then that's when you need to monitor. And then go back to the father, and if the father is a homozygote, you skip fetal testing and you just pick the cell-free DNA or the amnio, and you go straight to MCA. And this here we'll kind of talk about once we start the MCA and down is kind of what some of the rest of the talk will do with, so we'll go through it. And it just kind of depends on the multiples of the median of the peak velocity at a certain gestational age, what you kind of do next. So Dr. Brouillette wanted me to talk just a little bit about this. So we used to do amniocenteses on these on the fetuses, or the mother and the fetus, routinely whenever we thought they were at risk for alloimmunization and anemia. And we used to use the Delta OD 450. And that was a test where you would do an amnio on the mother, take some of the fluid out, and run that fluid through a spectrophotometer to get a certain value and compare that to either the Queenan curve if the baby was less than 27 weeks or the Lilley curve if the baby was over 27 weeks. And they did the same thing where they compared it to multiples of the median and treated thereafter. But since it's a much more invasive process versus the MCA Dopplers, and the MCA Dopplers are a good screening tool for fetal anemia, we've since adopted using the MCA Dopplers on these babies. And these are some of the curves. And you can see here the Delta OD 450 value here, and weeks gestation over here. And you can see as the OD 450 goes up, you get more affected. Yeah, this is, I don't know much about this. So.
And hopefully you'll never have to do it. But anyway, so we would do a spectrophotometric analysis of the amniotic fluid, and that's actually this curve right here. And that's actually what it look at. It come on this graph paper, and this is the actual absorbance of the light at that in the spectrophotometer. And then we would look at 450 nanometers, which is this area right here. And then by taking the difference from the baseline to the peak, that's the delta, the change in optical density at 450 nanometers. And then we would take that measurement and we would put it on this Lilley graph. This is a Lilley graph. If you had zone 1, that was generally unaffected baby. If you were in zone 2, then it might be affected, may not. And if you were in zone 3, then these were babies that were in trouble, that were severely anemic. And you would usually have to do at least 2 measurements, and that's true of looking at MCA Dopplers as well, because you want to look at the trend. And so what you see early in pregnancy, this is 27 weeks, and the reason this Lilley graph, this is the Lilley graph right here, this is the Queenan curve. The reason this was started at 27 weeks was when Lilley, back in the 40s and 50s, was doing this work, we didn't resuscitate babies less than 27 weeks. So those are basically considered non-viable, so they just really didn't do anything with those fetuses. So that's why this starts at 27 weeks. And so you would do these measurements, and then you would plot it on this graph based on what the OD was and the gestational age, and then you would look at the trend, and hopefully you would see a downward trend. Bilirubin in the amniotic fluid earlier in pregnancy is much higher, because you see how these slope down, and then as gestational age increases, bilirubin decreases. And then when we started treating fetuses earlier and earlier, that's when Dr. Keenan made his curve, and so then he had the high zone, the intermediate zone, and then the unaffected zone. And again, it was really important to look at, I don't like this microphone. Pops a lot. And it was to look at the trend. So the other thing I want to mention before you get further into Dopplers, for the cell-free DNA, the only thing we can test for currently with cell-free DNA in the maternal serum is the fetus Rh negative or positive. Okay, we can't test for any of the irregular antigens, so we can't tell if the baby has little c, big E, Kell, Kid, Duffy, M&S, and so forth. So for those, we're just going to look at the fathers, try to determine if he's heterozygote, homozygote, depending on what the antigen is, and then base our management somewhat on that information as well.
Thank you. Couldn't have said it better myself. Okay. All right, so now that we don't do OD 450 anymore, we've moved on to the MCA, peak velocity. So the kind of question is, what does it tell us? What is it looking at? So what you're doing is an ultrasound on the fetus, looking at the vasculature in the brain, looking at the middle cerebral artery, and you're measuring the velocity, the peak velocity of it. But the reason why that's important is Blood is a fluid, and it has different solutes in it, particles in it. The more solutes and particles it has, the thicker it should be, the higher viscosity it should have. The thinner it is, the faster it should move. And if you are anemic, you have less blood cells, and actually the CO2 is up as well. That's another part of it. But and it should move quicker, and that's why we measure the peak velocity. So the less blood, the quicker it should go. And this is just a little cartoon kind of demonstrating viscosity. And the fluid on the left is a thick green slime, evidently. High viscosity, slower flow. And the one on the right looks like water. Less viscous, moves a lot faster, has a higher velocity. And this is just a little anatomy, just to kind of remind you. Our middle cerebral artery right here comes off the internal carotid artery, okay, and this forms a portion of the circle of Willis here in the brain. And this is another cartoon of it, and then we're going to kind of flip it just because this is kind of how we're going to see it here. Okay, so you see it's turned sideways, the middle cerebral artery is over here, which is in the ultrasounds right here. Okay. So again, this is the baby's head over here, circle Willis right here, and our middle cerebral artery. And this is just a picture of, like we saw earlier, some peak, some velocities from the middle cerebral artery, and that's how they're plotted. And like Dr. Brouillette was saying earlier, you take 2 to 3, and you want to measure it right here near the insertion site here. Okay, well, this is a picture of Christian Doppler, just so we can kind of get understanding of some physics of the transducer and everything. And I'm going to try my hand at it first, and you can kind of step in if. So this is Doppler here. He was a physicist from Austria, and in 1842 described the Doppler effect. Now, the Doppler effect, kind of the way I learned it in school, they always talked about like a siren on top of a train as it's coming at you. Those waves are compressed. The frequency is it's stacked more, so it's a higher pitch sound, higher frequency. As it goes away, those waves are kind of extended, and it's a lower sound. So you kind of dealt with frequency and waves and things like that. And this picture has a very important formula here. So this FD right here is the Doppler shift, or what the transducer picks up as the waveform in ultrasound. This FC right here is the frequency that the transducer sends back. So our transducers emit sound. It's reflected back different wavelengths by the tissue, and then picked up, and then kind of interpreted by the machine. So we don't have to do any hard work. V is velocity, usually of the blood flow, and this is kind of the more difficult part, is some trigonometry, geometry, the cosine of an angle. And I don't have any of the cosines of the angles memorized, so we'll go through a little picture and chart to kind of go over that and get that in your mind. And then C here is just a constant, and in this situation, it's the velocity of ultrasound in water, which is about 1,540 meters per second. So we'll kind of come back to this formula here. Yeah, thanks. So in this little picture, again, this is our transducer, so FC. So that was the frequency sent by the transducer. Then you have, so your cosine A, right, your cosine angle. Your angle here is the angle of your wave that you're sending with the tissue, and in our case here, our middle cerebral artery, and that's this angle here, where we're going to use the formulas in the list to kind of figure out that cosine. And it'll make a lot of sense in a second. I know this probably doesn't make a lot of sense. Okay, so let's move on. Here's the picture I was talking about. So this is all about the angles here. And all this is saying, these values here are the cosine of certain angles, and here are the angles. So if you think about it, a cosine angle of 90 degrees, okay, so perpendicular to our vessel. Okay, they didn't put a picture down here, but our vessel would be perpendicular to our transducer. That's 0, okay? And so if you look back here, this is in the numerator. If cosine that angle is 0, then this whole top part is 0, and then our waveform that we get back is 0. So you'll just get a flat line on your ultrasound that you're looking at, and you're like, oh, well, I'm doing it wrong, or there's no flow, I don't know. So you can't be perpendicular to it. And if you're perpendicular to it, okay, imagine so that this line is your vessel, your wave kind of cuts it, and since it's cutting it down this way, you're actually seeing the cross-section of it. So you don't ever want to take a cross-section of the middle cerebral artery. You always have to be looking at the vessel lengthwise. And the reason for that is, so if your angle is 0 degrees, okay, if you imagine this vessel here moved up here, your transducer would be coming straight down into the vessel, and that will give you, and I'll show you a picture, but it'll give you your longitudinal view of your vessel. And that's your cosine is 1, so it makes this whole, this part 1, and there's not much variation. Then what your transducer is showing is true at that point. Hope that made sense. It will after this picture, I think, because this is what did it for me as I was studying and reading for this. I couldn't figure it out. I was asking Dr. Gwen, like, help me out with this physics and geometry. So she helped me out a lot. So yeah, that's kind of why I asked. So if you put a picture of the transducer here, as you see, the signal is coming in at 0 degrees into the vessel, okay, giving you that cosine of 1, a true transducer reading. And if you kind of picture, our screen, we're looking at it from the top down almost, so you're seeing this flat picture, okay? Because I was thinking of it kind of the opposite way, but so this is what you would see. This is why you want the longitudinal, because of all the angle depends or makes a big difference here when you're getting your waveform. Whenever we do Dopplers, you should kind of be doing the same thing, but when we do the SD ratio, it somewhat takes out that error. Okay, you can be angled. You shouldn't be 90 degrees, but you can be angled and still get an accurate reading that is clinically significant, but because it's a ratio, and it takes out this need to be that meticulous. But I guess that's why the MFMs do this, because it's hard. And Dr. Brouillette. Okay, again, so same picture here, just showing you that's the angle that we're getting, that's 0 degrees, but our picture, when you look at it, is actually kind of like you're looking down onto it. So. Okay, so now that all that's out the way, so we get these Dopplers, these peak flows, and Lise kind of started talking about it earlier. When you should start testing, and you want to get them every 1 to 2 weeks. You want to follow them very, very closely, because this can change very quickly. And then, like we talked about, the testing and the management depends on the gestational age and what these Dopplers are. And then, as long as your peak systolic flow or velocity, is less than 1.5 multiples of the median, then you can continue following closely and then start antenatal testing at 32 weeks. And to kind of just talk about multiples of the median, so I don't look at it a lot, so I didn't truly know what it was, or the significance of it. A multiple of the median is just you take a result, okay, so a peak velocity in this case, and you divide it by the median of, like, all the median of a number set, and that's when you get your multiples of the median. So it's literally just 1.5 times the median that's found at that gestational age. Okay, and so once our peak velocity is above that critical value, no matter the gestational age, as long as it's above 24 weeks, you begin antenatal testing, and then you can kind of change your management. It'll go back to that the flow chart from earlier. But if your gestational age is less than 35 weeks, then you should perform a cordocentesis, or send your mother and baby somewhere where cordocenteses are performed. However, in this patient, she had Hep C, so we couldn't do that. And I think that's why the first time she was admitted, we continued testing. We repeated the Doppler the next day. It had gone below the critical level. Testing was fine, so we decided to follow her closely again. And then again, if the gestational age is above 35 weeks, then you trend the systolic, the peak velocities, and it didn't really give like I didn't find a hard limit, but if you have kind of 2 in a row, then you just deliver, huh?
Clinical
Yeah. So, but I would say, yeah.
Big picture.
Yeah, and that's what we did with Our Lady. I mean, she was 32 weeks, so obviously less than 35, but we couldn't monitor. We couldn't do a cordocentesis. We didn't really know what the peak flow. We didn't know what the hematocrit was in the baby. Plus, she couldn't have gotten transfused anyhow, so we decided to deliver. Now, this is just a picture of kind of what the peak velocities look like. Relative to the median. So the median is here, and these top and bottom lines are 1.5 multiples of the median. So that's kind of the normal you see. And then our anemic babies, they're usually above the median, and here is your critical. So, and I have just a couple articles, just real quick, just to kind of look at our MCA Dopplers, why we can use them in place of that OD 450 and why we trust them. So this first article is called Prediction of Fetal Anemia with Doppler Measurement of the MCA in Pregnancies Complicated by Maternal Blood Group Alloimmunization or Parvo-B19. It was by Delhomme, I don't know how to say that, et al. In the Ultrasound in Obstetrics and Gynecology in 2001. They looked at 40 singleton pregnancies who underwent the MCA peak velocities and underwent cordocentesis after, so they could correlate it to hemoglobins of the fetuses. And over those 40 pregnancies, they actually had 165 separate episodes of looking at the Dopplers with corresponding cordocenteses. And they found a significant inverse correlation between the peak velocity, so the higher velocity, you had a lower fetal hemoglobin. And their numbers that they found were 73% sensitive and 81.5% specific. And the second article is very similar. It's called Prediction of Fetal Anemia by Middle MCA Doppler by Shorbadji et al. It's in the Middle Eastern Fertility Society Journal in December of 2012. And they looked at 30 singleton pregnancies. They had to be non-hydroptic, and they had to have known red cell antibodies, and they kind of did the exact same thing. They looked at MCAs with cordocentesis so they could correlate a fetal hemoglobin to the peak velocities. They found this same thing, an inverse correlation between velocity and fetal hemoglobin, but their sensitivity was a bit higher in this study. It was 90.5%. Their specificity was a bit lower. It was 78.6%. But they only looked at one episode per pregnancy, so their power is a little lower. And we'll just talk about cordocentesis a little bit. It's also called percutaneous umbilical cord blood sampling, or PUBS, and it's an ultrasound-guided sampling of the blood from the umbilical vein. And we get it to look at the hematocrit. And the hematocrit is what we use to determine if a baby needs a transfusion or not. And our threshold that we use is 30%, and you want to try and get the hematocrit up to 40 or 50%. And luckily, Dr. Brouillette did not want me to go through the calculations and all that stuff, so I appreciate that. So if the hematocrit from your initial cordocentesis is 30% or above, then you can just watch the baby and do another cordocentesis in 1 to 2 weeks to make sure it's stable. If it's less than 30%, then you transfuse, and then you every 2 weeks do another transfusion because you'll get a steady drop in the hematocrit and or hemoglobin because those antibodies are still there destroying the red cells. So when should delivery be considered? It all goes back to the peak velocities. While you're following these patients very closely, if their peak velocities stay below the critical range, so below 1.5 multiples of the median, then you can safely deliver at anywhere between 37 and 39 weeks, depending on how well the baby's doing and the mom's doing and everything. If it's above the critical value, as you've seen, when you look at the hematocrit, the fetal status, you trend the velocities and make a decision based on that. And if everything is stable, you still want to deliver closer to 37 to 38 weeks. And any compromise along the way, kind of like our patient, then you give steroids if warranted, and then you deliver as soon as you can. So these are just some of the summary of the recommendations when it comes to kind of screening our patients. So again, as we talked about before, type screen should be attained at the initial visit every pregnancy. And part of that is because you don't know what could have changed between the last the last delivery, and now especially our patients sometimes don't come to the doctor, or they go to the different hospitals. They may get transfusions. They may have not gotten the correct care just because they don't show up to their appointments sometimes, and not gotten the Rhogam or whatever. So you gotta get a type and screen every time. And then if they are Rh negative and they're getting Rhogam, you should get a type and screen there. And the rationale behind that is we're drawing blood anyway. You don't know what could have happened in that instance of time either. It's a good opportunity to get one, and you don't want to miss something that you otherwise would have picked up. So in the first pregnancy, where red cell antibodies are detected, the titers are generally used to guide fetal surveillance with Dopplers. Lise talked about earlier, most antibodies are 1 in 32. For Kell, we use 1 in 8. If they're above that critical value, then that's when you want to start your testing with Dopplers. And in the subsequent pregnancies, you can just start ultrasound screening of the babies at 16 to 18 weeks, because you know they've had disease before. There's no need to follow the titers. So if red cell antibodies are found on the type and screen, and Lise talked about this, paternal and/or fetal testing is advised. And the reason why you want to look at the father first is because it may take away unwarranted testing or treatment. If the father's unaffected, then the baby could be unaffected. You don't need testing. And we just talked about all this. Peak velocity above 1.5 multiples of the median warrants cordocentesis and hematocrit evaluation for possible transfusion. And the delivery is based on the whole clinical picture, as Dr. Brouillette had talked about. And that is our part. These are all of our references here. And it's me and Caleb. Yes, sir.
I'm sorry, it came a little bit late. We also started with the presentation that this is RH sensitized, also in the United States. We don't see these diseases. Most of us manage hundreds of such sensitized fetuses. It is a devastating disease. As you know, Dr. Lilley came out with this book, the New Zealand obstetrician whose daughter is now 40 years now, devised this in 1963. So Lise and I asked you to put this slide here. Dr. Rose Brouillette, and you guys did a great job. But if you have on your horizontal axis the gestation, this is what a normal pregnancy does. So what you're looking, because of the absorption by Beard-Lambert law, what is Beard-Lambert law? So you know, you're sitting in your physics class, okay? Beard-Lambert law applies to any substance, which means that the concentration of a substance according to optical density for that absorption is equal to the optical density. In other words, the optical density is high, that's the concentration. Bilirubin, as you can see, depending on whether it's protein bound or free, in this case it's very little protein, it's anywhere between 440 and 460, there's a range. So that's giving you the concentration. And as Rose said, you're plotting it. So zone 2, subsequently Lilley's curve was modified into zone 2A and TV. What you're really looking for, when Dr. Lewis was here, we were doing a lot of these fetal transfusion. If the baby goes from 2 to 2A to 2B to 3, that's a fetus who will get into trouble. And the reason I asked you to put this graph is the recommendation, or it is, you're going to lose a fetus if you don't do something, because we don't understand why they die, because the thinking is that they are having heart failure, that's why they have a sudden death. So you want to get the fetus out if they are 28 weeks. That's a mother who should be put on steroids for 48 hours and get the fetus out in 28 weeks. And those of us who have seen it, these are kids with gross hypops, it's all over the face, chest, myasthenitis. So it's because of the anemia and heart failure. That's what you came to in your subsequent discussions. So that's number 1 point. Number 2 point I want to make, you talked about Rhogam. As you know, you're looking at, it's never sensitized in the first pregnancy because of the receptors she talked about. So the first baby is positive, delivery is there, then you want to give Rhogam to prevent the subsequent. And the mother or the dad has to be either homozygous or heterozygous RS positive for the fetus to get one of those genes and to be sensitizing the red cells. Okay? So that's what is causing the anemia. So what you're looking at in your doctor, my understanding is all you're doing is you're looking at anemia. any anemia in the fetus is going to cause that, right?
Yes.
We talked about viscosity. Viscosity is a straight line. If I look at, there's a complex formula, I don't want to go into it. So length of the tubing, the radius, and the substance you're looking at. So as far as blood is concerned, red cell mass is the most important thing. So if you look at the red cell mass, if you've got a horizontal axis here, the hematocrit on this axis, true viscosity measured on the vertical axis, it's a straight line till you get to 60, 65. So therefore, as long as you're less than 60 or 65, there'll be a lot of changes there in terms of viscosity of the flow, because part of the equation is flow, which depends on the diameter, the length of the tubing, there's a pi in that equation. So one has to be very careful that can give you false. If you look at your own curve, which you presented, the upper zone, you go back to your systolic flow, the green curve. See, you don't have to stop there. See this curve? So the normal and the higher middle cellular artery peak velocity is overlapping above the median. So it's very difficult on that. All you're saying is that fetus is anemic. That's all you can say. You can't correlate with the other. RH gold standard is still modified Lilley's curve. And as I'm saying, that what we are worried about, if it's a sensitized baby, you will get it out before 28 days. Okay? So what has to do that? And the fallacy of that, one has to be very careful when you're doing an amnio. If you've got a bloody tap, your red cells are breaking down, you should be producing bilirubin and give you a false number. So, and again, when you do an amnio, one has to be very careful because you can induce premature labor, as you know. The data from the old days shows that there's a 5% mortality rate. There is anywhere from 15 to 25% premature induction of labor, so one has to be very careful. So, and again, we do it. One of the things, again, I want to bring up, maybe some of the senior OB folks who have any experience in it would say, you're looking for evidence of hydrops in the fetus. So you're looking for edema in the fetus. That's what it is going to be wrong. Let's say you have ascites or skin edema, facial edema, then you'll be worried.
Well, certainly, when we're doing our MCA Dopplers, we're looking at the whole fetus. I mean, we're not just doing MCA Doppler, that's it. So we're going to look for any signs of hydropsy, pleural pericardial effusion, ascites, etc. And, if we have those things, then of course you can see that some of these anemic fetuses actually have normal MCA Dopplers. So you have to look at the whole big picture, the whole clinical picture. The other thing I want to say about Rhogam is that you have to understand Rhogam is, it's a dose, and I think it's 150 micrograms if I remember correctly. And what it does, it will cover 15 cc's of fetal cells and 30 cc's of whole blood. And so if you have a large fetal maternal hemorrhage and you only give one vial of Rhogam, your standard dose, then that mother will become immunized if she's Rh negative and that child is Rh positive. So when you deliver an Rh negative mom and you suspect that there's possibly a large fetal maternal hemorrhage because there was an abruption or something else happened, maybe she had a sinusoidal pattern for some reason, and so there's suspicion, then you have to ask your blood bank to quantify the degree of fetal maternal hemorrhage, and they can do that. Clyhyrbenfy is the test they do, and they can quantify how much fetal hemorrhage there is. And then by quantifying that, you can determine how much Rhogam to give. So you may have to give multiple vials of Rhogam, not just one. The reason we give Rhogam during pregnancy is because there can be fetal maternal hemorrhage. It's usually very microscopic, small amounts during pregnancy, most commonly in the third trimester. It can happen in the third trimester, most commonly at delivery. But because it happens in the third trimester, that's why we give antenatal at 28 weeks. It's uncommon to happen prior to the third trimester. But if you do procedures, and as you all know, there's amniocentesis, if the mother had abdominal trauma, if she had vaginal bleeding, which possibly was associated with fetal maternal hemorrhage, she had an ectopic pregnancy, a miscarriage, etc., then you're also going to give Rhogam to that Rh negative mom. If a mother is immunized, and usually the first pregnancy, the baby is unaffected. Subsequent pregnancy is usually, and we're talking about Rh negative with antibodies to NTD antibodies. Subsequent pregnancies, the first one usually is mild, but each successive pregnancy, because of the amnestic response she's having to that antigen, her antibody titers are going to get higher and higher and higher, and so the subsequent pregnancies, the anemia generally is worse in the fetus and neonate. I think Dr. Koo wants to talk a little bit about management after delivery. Yep. So I'm going to turn that over to you. So that's why you can't really use titers. After the first pregnancy, titers are totally useless. You can do them, but they're not going to tell you what's going on with that baby's, if it's anemic or not. That's why you need to do your MCA Doppler. And again, you have to look at the whole clinical picture, not just a single volume.
I know you tend to trend the MCAs to kind of look and see if this, again, they can be within that normal range and maybe still anemic. Is there a level that you look at when you start considering to really look closer or worry about high drops more?
Well, I mean, high drops usually, like if you talk about babies developing high drops, usually it takes, the instance would be, let's say, like a cardiac arrhythmia. Usually it takes about a week before you become hydropic. So that's why we do them once a week. But if you were real worried and you could just do it more often. You could do it twice a week. You could do the fetal testing, non-stress tests, etc. You could look for sinusoidal pattern on your non-stress test, which is a type 3, as you know. But part of the problem with this particular patient is she was very non-compliant with testing, and she had a lot of social issues, shall we say. So that was, I was just happy we got to 32 weeks. So
She was also
very happy.
she had hepatitis C.
C.
So when you have a liver disorder, your amnio is unreliable if she's jaundice.
Well, we don't, I can't even remember the last time I did an amnio for delta DPD or 50. I mean, that's probably 1990 something or
Right,
other.
it was very common.
So, yeah, so we wouldn't probably use that to guide. If her Dopplers are abnormal and we're suspicious of anemia, then we would do cordocentesis. And you can do either fetal artery, umbilical artery, or vein. So, and that, we would look at that. We would directly look at that fetal hemoglobin. So.
All right. There are a number of ways that babies can be affected by hemolysis, and we're just focusing today on the alloimmune aspect. How do you, oh, there we are. Just a few words on blood group antigen. Traditionally, we name them alphabetically, or the first person produced antibody against the antigen, which is Duffy, Diego, etc., and alphabetically ABO, Immunex, etc. And since the International Society of Blood Transfusion standardization is now grouped into blood group systems, collections, or series. And the blood group systems are the ABO. These are antigenically unique. And they're now just like the ICD-10. Well, actually, this is long preceding ICD-10. Yeah, that's right. The first 3 digits is the blood group. The next 3 digits is the order for which the antigen was discovered. The collections, they are antigens related either genetically, biochemically, but don't meet the criteria for a specific genetic basis, a single gene. And in this series, these are the rest of the antigen. They can't fit them in either way, but it's present in less than 1%. They name them as 700 series. And the common ones, the ones that present in over 90% but can't be classified as blood group or in the collections. Currently there are 11 antigen. When you add it all up, there's about 61 antigens today. Hemolytic disorder, as we talk about that, the D and ABO are the overwhelming majority of the situation. But there are minor blood group incompatibility. And it's serious, about 15,000, 20,000 babies from memory or pregnancies, less than 0.1% is due to the so-called minor blood groups. And they're mostly anti-big E, little c, and kill. And there's a separate report, 30 cases of that in that particular series. It's mostly little c, anti-little c, anti-big E, and a number of other things, including the JK. If we talk about the anti-KEL, we talk about maternal antibody, but apparently in small series, it actually said the extent of hemolysis, the severity, doesn't actually correspond to the titer. And in some cases, and most of the situation in terms of hemolytic disease, we're concerned about anemia and thrombocytopenia. But apparently, some of these babies can have pancytopenia. And if we go back to RH hemolytic disorder, there's really 5 antigens: big C, little c, big D, there's no little d, and big E and little e. And it's very uncommon in the Asians and North American Indians, about 5 to 6% in African Americans, and about 15% in North American Caucasians. And apparently about 9% of all pregnancies in Caucasian women involve RH negative women carrying RH positive fetus. And roughly, according to one estimate, about 66% of the pregnancies at risk means RH negative mom with RH positive fetus will develop Alloimmunization, and even less than 0.1 ml of fetal blood apparently can elicit maternal immunization. And occasionally, the immunization may not be evident, but I guess it depends how high one low, until the subsequent pregnancy when the mom's pregnant with a second RH fetus. Just briefly, what do we see from a neonatology perspective? And certainly it can start from a fetal stage, which obviously OB is involved, but the consequences are primarily from anemia, as we all know. And one of the things to compensate, the fetus develop extramedullary erythropoiesis, in other words, other than the bone marrow. So the classic manifestations, hepatosplenomegaly. Liver dysfunction can happen in extreme cases, which subsequently associate with hypoalbuminemia, coagulopathy, and obviously hypoxia. Depends on how much anemia is present, and in extreme cases, heart drops from a physical manifestation. Splenic sequestration from red cells coated with antibodies are sequestrated in the spleen, and which may develop secondary hypersplenism and thrombocytopenia. And the other consequences of hemolysis, these tend to be more postnatal rather than prenatal, because mom can do the job most of the time from a complication. It can have primarily the indirect hyperbilirubinemia component, but the direct hyperbilirubinemia anemia certainly can happen postnatally, especially in the presence of liver dysfunction and in situations of phototherapy and bile stasis. Islet cell hyperplasia in pancreas has been reported. And as we all know, it depends on what are the comorbid condition. And if the baby's in trouble in utero, in a potentially viable gestation, they come out, and the commonest one obviously is prematurity. As far as management and complication, depend on how the baby is or the fetus progressing. And in most cases, we get them in pretty good shape because of the regular OB monitoring. So even though some of them are premature. And in terms of treatment, for these, it's basically just primarily asymptomatic support. Manage the anemia, depends on the extent and depends on other situation. They may only need a simple transfusion versus exchange. And in some situation, particularly the RH diseases, you may have late anemia, steady drop in hemoglobin. And the reason, around about 2 to 3 months, that's the end of your antibody. And most RHDs, IgG3, the half-life is only about 7 days. So you get your acute peak and then a steady drop after that. And for most kids nowadays, we can get away with phototherapy with our exchange transfusion. So your antibody's still there. So the late anemia is the one that one needs to be careful of. This usually happens after they get discharged. Hyperbilirubinemia, as I said, overwhelming majority of the time we can get away with phototherapy alone with our exchange transfusion. Thrombocytopenia, DIC, all these can be supported symptomatically, and whatever other comorbid conditions. And come back to this baby. This is a little baby girl, APGAR score 6 and 8, birth weight 1955 gram, and from a clinical perspective, it's consistent with about 33 weeks. And there's no hepatosplenomegaly, no petechiae, no heart drops, no heart failure, and baby was good from the beginning. And these are the labs. Hemoglobin was 14, and platelet counts 158,000. White cell differential is fine. Reticulocytes a little up on 8.8%. Was Coombs positive with anti-JKB. The initial bilirubin on admission was 4.4 total and 0.3 direct. Total protein albumin is relatively normal. The albumin subsequently increased to 3.5 gram per deciliter on follow-up. The liver enzyme is reasonable. The renal function, blood glucose were normal. The hemoglobin hematocrit remained stable during the hospitalization, and retic count went up to, I think, 10%. And platelet count also increased spontaneously. The maximum bilirubin was 13.6. That happened about 32 hours, and it's fairly rapid, and then came under control with total phototherapy about 4 days. Baby was clinically well, was fed from day one. And baby, at least from a jaundice perspective, did fine.